And I will go ahead and continue. I actually have two more slides, okay? So this one and the next one. So this is again pathophysiology, and renal failure and overall progression of kidney damage very much has to do with the extent of kidney function, as I mentioned earlier. AKI, so this is acute kidney injury, can occur during chronic renal failure. Let's say sudden stress or something's imposed on already marginally functioning kidneys. Um, there's three different stages of acute kidney injury or that can lead to renal failure. We have the pre-renal acute kidney injury, intrarenal nephrotoxic acute tubular necrosis. We have post-renal acute kidney injury, and then we have oliguria. In oliguria, there's three stages: alteration in renal blood flow, tubular obstruction, and tubular back leak, which I will go ahead and explain. But going into pre-renal acute kidney injury, it's mainly caused by poor perfusion. So poor perfusion of water, anything blood going towards your kidneys, can be caused by hypovolemia, many times of burns, hemorrhage, sepsis, inadequate cardiac output, vasoconstriction. NSAIDs cause a lot of vasoconstriction. So that can lead to pre-renal acute kidney injury. So what happens is the GFR declines because of the decrease in the filtration pressure. This eventually leads to a failure of the kidney able to restore that blood volume, the blood pressure, and oxygen that would be delivered towards your kidneys. What happens when there's no oxygen? We get ischemic injury. And then from this, we get acute tubular necrosis or acute interstitial necrosis, which is a more severe form of AKI. Then we go on and we have the intrarenal meaning inside the kidneys. So we have nephrotoxic acute tubular necrosis, which can be produced by radiocontrast, and there are numerous antibiotics, especially aminoglycosides. Acute glomerulonephritis, vascular disease, which can be malignant hypertension, or DIC, disseminated intravascular coagulation. If coagulating, there's obstruction, there's no perfusion, or as well as renal vasculitis. A lot of times when they get surgery, allograft rejection or interstitial disease, drug allergy, infection, a tumor, anything that will also start decreasing any blood flow inside the kidneys. Acute tubular necrosis is caused by ischemia, occurs more often again by surgery, which is usually 40 to 50% of the cases. But also it's associated with sepsis, like I had mentioned before, obstetric complications and severe hemorrhage, trauma, severe burns. Hypotension is also associated with hypovolemia, which means no perfusion, which leads to ischemia. And then this leads to inflammatory responses, more and more decreasing blood flow, generating eventually toxic free radicals, and causes cellular swelling and injury and necrosis. If we go on to post-renal acute kidney injury, you can see that what I also put possible causes of each of these, so you could have a better understanding. But I'll go ahead and explain. So post-renal acute kidney injury is a rare, but it's usually does occur, and it occurs within the urinary tract. What happens is there's an obstruction in the urinary tract and affects the kidneys in the both ways. So it could be a prostatic hypertrophy, bilateral ureteral obstruction, tumors, neurogenic bladder, a pattern of several hours of anuria with flank pain, followed by polyuria is a characteristic finding. So the obstruction causes an increase in intraluminal pressure upstream from the site of obstruction with a gradual decrease of the glomerular filtration rate. And then this type of renal failure can occur after, let's say, a catheterization of the ureters or a procedure that causes edema. So anything can really lead to acute kidney injury. Anything that's not in our body, can lead to anything. So lastly, I'll go through oliguria. And oliguria means less than 400 mLs in 24 hours of urine. And there's three stages. So there's alterations in renal blood flow. There's post-renal, tubular obstruction, and again, tubular back leak. And so what are the alterations in renal blood flow means the efferent arterial vasoconstriction may be produced by the intrarenal release of angiotensin II. Or there may be redistribution of blood flow from the cortex of the medulla above our kidneys down to the auto-regulation of blood flow, which may be impaired, resulting in the decrease, again, glomerular filtration rate. Usually this changes in glomerular permeability and decreased GFR, then eventually result again to ischemia. Tubular obstruction, so anything could be obstructing the tubules. There could be a slough cells, there could be cast formation, ischemic edema resulting from tubular obstruction, which eventually causes retrograde increase in pressure, reduces the GFR. Then renal failure can actually occur within 24 hours in obstruction. Because in obstruction, you're completely taking away any oxygen and any blood flow. And then lastly, we have the tubular back leak, which just means glomerular filtration remains normal, but the tubular reabsorption of the filtrate is accelerated as a result of the permeability caused by ischemia and increased tubular pressure from obstruction. So again, everything really does go back to ischemia. Whatever is not causing blood flow to your kidneys. And then you can go over the table I posted here. It's just dysfunctions of the 3 stages. And I'll just let you know. So what can cause, pre-renal, hypovolemia? What can cause intrarenal? So anything, tubular necrosis, cardiac failure or shock. And then post-renal. So what can cause post-renal? So an obstruction, blockage, neurogenic bladder. And then I'll go on a little bit more. Okay, sorry.